All right, folks, welcome to another live and interactive positive aging community discussion. We've got a good one for you today, but before we dive in to our discussion with Howard Gleckman, let me go through a little bit of housekeeping, especially for those that may have never been to one of our discussions before. First off, the best part about these is they're live and interactive. So you'll be able to type in your questions and at the end of the discussion, and hopefully we can have an interactive discussion. I might even do a little after party for this event today. But these discussions are brought to you by the Positive Aging community, and we're able to put these together free of charge, as well as the Positive Aging Sourcebook, thanks to the support of our Positive Aging community champions. These are organizations that support what we're doing. They're easy to connect with if you go to proaging.com, but you can also reach out, connect with me, schedule time, send me an email. I love helping people make connections, find solutions, and uh, in this area of aging and longevity. At proaging.com, you can also order free copies of the Positive Aging Sourcebook, as many as you'd like. And then today's discussion is going to be recorded. So if you have to jump off early, if you want to share it with somebody, it'll be at proaging.com later this afternoon on the left-hand side where it says on-demand recordings, along with our chat transcript and any resources we talk about. Then on the right-hand side, you can see what we've got coming up. And what I'm going to do is quickly go through our schedule coming up, and then we are going to dive in to a great discussion. So next week, we're going to be talking with the author of The Loving Approach to Dementia Care. It's the Laura Wayman, who's known as the Dementia Whisperer. So that'll be a great discussion. Then on April 30th, we're going to learn about urban polling. You ever see folks walking around with two walking sticks? Well, you're also going to learn the benefits to that, but also an exercise program that is centered around these polls. Um, every month we have a panel of aging life care managers, and in May, which is happens to be National Life Care Month, we've got another panel on May 7th. So tune in. That's a great place to get a lot of questions answered that you may have about your own planning or your loved ones. On May 13th, we're going to be talking about the journey of the well spouse. So often, if we're lucky enough to have a partner, our health is changing at different times. And so one spouse may be a caregiver, and we're going to talk a little bit about that. And then on May 14th, if you haven't heard about the GUIDE program, this is a program, a CMS program that I think Howard's going to talk a little bit about today, that is supports those with dementia. You're going to learn about that. You're going to hear from some folks that are actually implementing the GUIDE program out there. And then I on May 29th, I literally just booked this today. Ginger Smith, who's got an amazing story of a diagnosis with dementia in a nursing home for 2 years, placed on hospice, and now she is living independently and thriving. And in fact, this discussion is on her 88th birthday, where the day before her new book is going to be a new book written at Memoirs Her Life is going to be launched. That's going to be an amazing discussion. You can sign up for all of these at proaging.com, and you can hear the recordings if you miss it. Oh, and then last but not least, Late to Your Own Funeral, the brand new book that's just been written by Rachel Donnelly. We're going to be talking to her. Okay, that leads us to our discussion today. And I am super excited to have somebody that I have got to know over the years. We've done these discussions with the changing of the administration twice, but I don't think that there is quite the change. I know from the last few years when we had a changing administration. I don't think we've been encountering the changes that we're encountering today. So I'm thrilled to have Howard Gleckman with us today, who's going to talk about aging services in the Trump era. And Howard, number one, thanks for, I know you're really busy on this topic. Thanks for taking the time to meet with us today. Um, uh, I'm glad to have you.
Always good to be with you, Steve. And this is a topic of interest to a lot of folks I know. So very
Yeah,
timely.
yeah. Now, for those that don't know you, Howard, let's get to know you a little bit better. Tell us a little bit about your background and the journey that you've been on.
Sure. So I spent most of my career as a journalist, about 20 years at Business Week, where I was covering fiscal policy and healthcare. And then, like so many people, I suspect on this webinar, I had a personal experience. First, my father-in-law got sick, and we had to take care of him. And then my dad got sick, and we had to take care of him. And I realized, even though I had been covering healthcare and I knew a little bit of what was going on in that world, that the long-term care system, the system of caring for frail older adults, was a catastrophe. It was fragmented and disorganized, and the doctors didn't know about the social services that my dad needed. Uh, and I did what every journalist did. I started writing about it. I wrote a book called Caring for Our Parents, where I had the opportunity to actually spend a couple of years with families that were living the caregiving experience. I wrote about that in the context of policy. And then left Business Week, went to the Urban Institute, where I've been doing policy research, both in tax policy and in aging policy, ever since. And, the sad thing is, I wrote that book over a decade ago, and nothing's changed except more people have gotten older, and the system has gotten only worse.
Wow. And I dropped a link to the book on Amazon in chat for those that might be interested. Well, okay, you've got a lot to cover. And folks, I chatted with Howard before this discussion, and the format that he thinks is going to keep him on track and enable him to share as much information as he can with us is he's going to talk for, roughly 30 minutes or so, and share some insights. And then we'll do our best to respond to your questions. So what I urge you to do is as Howard's talking, if a question comes to your mind, feel free to just type that into Q&A or chat, and then Howard will do our best to run through folks' questions at the end.
That's great. I'm really looking forward to hearing people's questions and getting a sense of what you all are interested in. So there's a lot to cover. This is going to be kind of policy speed dating. I'm going to go through probably a half a dozen different topics, all related to older adults and their family caregivers. Um, and as Steve said, I'll talk for about a half an hour and then open it up to questions and hope we can have a good dialogue. So let me start with Social Security. President Trump, of course, when he ran for president the second time, said that or the third time, I guess, he said he would not cut benefits. He wouldn't touch Social Security, is the way he put it over and over again. I think it's probably true that he's not going to take any steps to actually reduce the amount of benefits people are going to receive, at least in the short term. But clearly, what we've all seen is with Doge, the Elon Musk initiative, what they are doing is limiting access to Social Security by beneficiaries and by applicants. They have made it impossible to get through to people on the phone. We're hearing more and more stories about people spending hours on hold trying to get through. They've closed a number of local offices. So they're making it very, very difficult for people to get information that they need, either to apply for Social Security or to deal with a problem that they might have. Keep in mind that Social Security is really a couple of separate programs. There's a Social Security program for older adults, the old age piece of it. And that's pretty straightforward. That's pretty simple. You apply starting after age 62, you can do it online. It's not too complicated. But the other part of Social Security is the disability program, which is much more labor intensive for Social Security. The waiting period between the time someone applied for Social Security disability and the time they got it was last year was 240 days. And the expectation is because of the staff cuts and the other kind of bureaucratic impediments that have been put into the program, it's now going to be well over a year. So in effect, there will be people who apply for Social Security disability who will die before they get their disability payments. Um, the other thing to keep in mind is while the president says he's not going to touch Social Security, not touching Social Security in itself creates a tremendous crisis. As you all may know, in about 9 years, the Social Security Trust Fund will be insolvent. It will be unable to pay all of the benefits that we have all been promised. And what that means is that we'll fall off a cliff, that immediately after Social Security becomes insolvent, everyone's benefits will be cut by about 23%. Um, that's going to have a dramatic impact, clearly, on older adults, on their families, and nobody wants to do anything about it. We've known this was coming for decades. The president says he doesn't want to touch it. There's almost no one in Congress who wants to do anything about it. So we've got this looming crisis. And when you hear politicians say to you, I'm not going to touch Social Security, what that means is we're going to take Social Security off a cliff. At some point, they're going to have to confront this program. Let me switch gears and talk about Medicare. The president also said there he wasn't going to touch Medicare. Well, I think what he means is he's not going to directly cut benefits for Medicare recipients, but that doesn't mean there are not going to be some profound changes in the program. There may be cuts to providers. And of course, the effect of that is going to be even more trouble getting access. All of us know what it's like to try to make an appointment with a primary care doctor. If Medicare is going to pay the docs less than they're being paid now, there are going to be fewer primary care docs, and access is going to be even more difficult. As I expect everybody on this call knows, there's two different kinds of Medicare. There's the traditional Medicare, the fee-for-service Medicare, and there's Medicare Advantage. This administration is particularly interested in Medicare Advantage, but it's delivering a number of inconsistent messages. And it's going to be interesting to see how all this shakes out. So on one hand, just yesterday, the administration announced it was going to increase payments to Medicare Advantage managed care plans by 5.3%. That's twice as much as Biden proposed to increase payments. And it's about $25 billion that's going to go to the insurance companies that run Medicare Advantage plans. You talk to the Doge people and they say their goal here is to cut government spending. Well, clearly they're not so interested in cutting government spending for Medicare Advantage. Dr. Oz, who's now running the Centers for Medicare and Medicaid Services, is a big fan of Medicare Advantage. Um, so it looks like on one hand, they're being much more generous to MA plans. Um, Already more than half of older adults are participating in MA. That number is expected to go up to as many as 70%, even without changes. And if the Trump administration makes some significant changes, that number could go up even higher. So what are they thinking about doing? Well, as I say, a couple of inconsistent things. You all remember Project 2025. This was the conservative manifesto that came out during the Trump campaign. Trump said he didn't know anything about it, but in fact, much of what he's been doing since he's been president has been following the Project 2025 playbook. Well, Project 2025 says explicitly they want to turn Medicare Advantage into the default option for Medicare. In other words, once you become eligible for Medicare, you will automatically be enrolled in Medicare Advantage unless you opt out and opt it back into traditional Medicare. So in that sense, they're looking to be very aggressive to get more people in the plan. And they've just given them this big bump in payments. On the other hand, when Oz was testifying before the Senate for his confirmation hearing, he was very explicit as saying that he wanted to crack down on this practice of upcoding. Medicare Advantage plans get paid more for higher acuity patients. So what they're doing is they are making it look like many of their patients have medical conditions the patients may not even know they have. There are also some other games they play to get paid more. And the bottom line is Medicare Advantage plans are paid more by Medicare for a similar patient than traditional Medicare is. So it doesn't save money and the Trump people seem like they want to pay them even more. On the third hand, just to make it a little more complicated, one of the big criticisms of Medicare Advantage plans is the prior authorization. Your doctor has to go through a big complicated approval process before he can prescribe a drug or a treatment or anything like that. That's gotten a lot of controversy, and Oz said he wants to do something to simplify prior authorizations. So we'll see how all this goes. Um, Maybe what we'll get is a more efficient Medicare Advantage program. Maybe we'll get a Medicare Advantage program where the insurance companies are just paid more and more and not really meeting the expectations of fully managed, well organized care, which is what they ought to be doing and what we all hope they'll start doing. Another thing to talk about briefly with Medicare are the drugs. Um, President Biden got Congress to approve this really interesting program where Medicare has started to negotiate drug prices. We'll start to see the benefits of that next year, only for 10 drugs at first. They've just approved 10 more drugs that'll be negotiated. When Trump was president in his first term, he proposed his own program for reducing the cost of Medicare drugs, never went anywhere. The interesting question now is Trump going to continue the Biden plan, or is he going to do something to try to change it, try to create his own kind of Trump branded Medicare drug proposal? I don't know, but it's going to be an interesting thing to watch. The first thing that the Trump administration did, however, in the drug area is they announced that Medicare and Medicaid will not pay for the GLP-1 drugs for weight loss. They do pay for it for people with diabetes, but they won't pay for it with weight loss. The Biden administration wanted to do that. The Trump administration has reversed them. That's something that's consistent with Robert F. Kennedy Jr. and his view about vaccines. We'll kind of see how that goes. Let me switch to Medicaid, which is going to be a very big topic of conversation. Fate is highly uncertain. A few weeks ago, the House passed its budget framework. It called for as much as $800 billion in Medicaid cuts over the next 10 years. The Senate just the other day passed its framework. It does not call for significant cuts, at least cuts of that significance on Medicaid. So the House and Senate are going to have to work this out. We'll see which way it goes. The only way you're going to get cuts of that magnitude are with block grants or sometimes called per capita caps. And the idea there is that the federal government pays about 70% of the cost of Medicaid. Right now, the way it works is the federal government, the cost of Medicaid goes up, the federal government just pays those additional costs. With a block grant program or a per capita cap program, what happens is the federal government pays only a fixed amount. And if the cost of healthcare goes up beyond that, or the cost of long-term care goes up beyond that, it's up to the states to pay the rest. The states don't have the resources to do that. If they went to block grants or per capita caps, it would be catastrophic for Medicaid. Not only for those Medicaid programs that benefit families with kids, working age people, but also for Medicaid that provides supports and services for older adults. Um, my experience has been that when older adults are competing for shrinking dollars with moms with kids, the older adults lose almost every time. So what could states do if they were faced with something like a block grant or a per capita cap? Well, when you think about older adults, think about nursing homes and home and community-based services. States are required under the law to provide care for older adults in a nursing home. They are not required to provide home and community-based services. Most of them do. They provide it under a waiver program, but it's not a mandated program. It's not a mandated service. My fear is that what will happen is the states will do what they have to do, which is nursing home care, and stop doing, or at least reduce doing, what they don't have to do, which is home and community-based care. And that would be a real tragedy. So we'll see how that goes. My own sense is that it's unlikely that Congress is going to go along with this idea of a block grant or a per capita cap. I think it's too controversial. Too many senators are quietly beginning to object to this. Um, Republican governors are objecting to it. My favorite data point here is West Virginia, which has a Republican governor, its entire congressional delegation of Republicans. There are 500,000 people in West Virginia. 30% of the population is on Medicaid, and 60,000 older adults are on Medicaid long-term supports and services. I don't think in a state like that that representatives and senators are going to vote to cut Medicaid, at least not make those big draconian cuts. But we'll see. I think it's more likely that Congress is going to do something else to Medicaid, and that is impose a work requirement. In his first term, President Trump said that he would allow states to impose work requirements. In other words, you needed to apply for a job, you needed to go to work before you could get Medicaid benefits. Um, Only a couple of states did it. It didn't work very well. Um, you might ask, what does this have to do with older adults? Well, older adults themselves are exempted from a work requirement, but their family caregivers may not be. So imagine you are somebody who is caring for your working age woman who's caring for mom, and you're on Medicaid because you're in a job that doesn't pay very much. Um, Now a work requirement's been imposed. You could lose your Medicaid if you continue to stay home and take care of mom, and that puts you in a awful position, and creates enormous challenges both for you and for mom. So, will they put work requirements on? I suspect they will. Will they exempt family caregivers? Don't know. And even if they try to exempt family caregivers, there's going to be a big fight about what do they mean by a family caregiver. Say somebody's being cared for by two kids, two adult children. Which of them gets the work requirement? Which of them doesn't? So, something to watch. It's going to be an important topic over the next several months. Keep an eye on it. I think there's also going to be some other changes to Medicaid that are going to directly affect people applying for the program. Right now, there's this look back rule. If you apply for Medicaid, they'll look back and see what you did with your assets for the last 5 years. If Medicaid deems that you have been giving it away so you could become eligible for Medicaid, they can deny you. It is likely that Congress is going to extend that look back for some period of time, maybe as long as 10 years. We'll see what happens. And I think the other place where we're going to see some direct impact on older adults and their families is with estate recovery. Right now, states can go back to heirs of people who are receiving Medicaid benefits. And let's say when the heirs sell the house, they can take back the amount of money that the older adult received in Medicaid benefits. States do that sort of idiosyncratically right now. I suspect you're going to see federal rules that are going to require states to do this in a pretty draconian way. So we'll see where that goes. Switch gears again and talk about the Older Americans Act and the Administration for Community Living. The Older Americans Act is that federal umbrella program that covers a wide range of dozens of programs for older adults. Meals on Wheels, congregate meals programs, adult day programs, um, uh, elder abuse prevention, falls prevention, a whole transportation, a whole range of those issues that are critical for older adults and actually younger people with disabilities as well who are living at home. Those programs are going to face some budget cuts this year. We don't know how big they're going to be, but again, as congressional Republicans are looking to find money to fund tax cuts and other programs that they favor, I suspect there's going to be some across the board cuts in domestic spending, and some of that is going to include the Older Americans Act. So it's something to watch very carefully for. The other thing that's going on, which seems kind of bureaucratic and technical, but is quite important, is most of the Older Americans Act programs are run by a small office at the Department of Health and Human Services called the Administration for Community Living, or ACL. ACL's only got about 200 people working for it. The Trump administration announced the other day that it was going to abolish the Administration for Community Living and divide up the work it does among three other offices at HHS. Um, and then a few days after that, they announced they were going to fire half of the staff of ACL. including all of the people who run the grants programs. Most of those ACL programs I was talking about, Meals on Wheels, congregate meals programs, transportation, all of that, they're run by contractors. They're run by maybe local governments or local community-based organizations who have grants or cooperative agreements with ACL. Well, what's going to happen when those grants need to be renewed or when the grantees have a question about how to deal with a problem that comes up? There's nobody on the other end of the phone because all the grants people have been fired. So even if the Older Americans Act continues, and even if it somehow continues without budget cuts, the challenge is going to be how does it work? How do they make it actually operate without people in the federal government who are actually keeping it going? Um, we'll see what happens. Um, when you think about community-based organizations and senior service programs, much of that money, as I said, comes from the feds. A lot of it comes from state and local governments. This area, the Washington, D.C. area, the DMV, is going to be particularly vulnerable to cuts in those programs because of what the Trump administration is doing in terms of firing federal employees. Montgomery County, for example, where I live, there are somewhere between 50 and 60,000 federal employees who live in Montgomery County. There are thousands and thousands of other contractors who live in Montgomery County. There are 130,000 federal workers who live in the state of Maryland. And I can say the same thing about Virginia, Northern Virginia, or DC. It's the same story. When those programs, when those people get fired, that is going to do significant damage to the tax base of both the county and the state and the District of Columbia. And of course, the Trump administration is also talking about cutting DC funding by $1 billion. So all that together means that those local programs, those county programs, those DC programs, or the state programs are going to be under significant funding pressure. And when they come under significant funding pressure, the community-based organizations, the other organizations that are getting grants from them or have contracts with them are going to be under pressure as well. So we're going to be facing in this area, I think, particular challenges just because of the changes that the Trump administration is making in terms of federal employees. Um, Another place to think about here is nursing homes. Uh, the Biden administration proposed what they called the minimum staffing rule, which was a very important, very significant rule. To my mind, it had its problems, but it made a real effort to make sure that, for example, there were nurses on duty in nursing homes 24/7. It's very controversial in the industry. The industry sued the Biden administration. The Trump administration is almost certainly going to eliminate that rule. They can eliminate it a couple of different ways. They can simply not defend the lawsuits, or they could just change the rule. One way or another, I think that minimum staffing rule is going to go away. Um, on the other hand, when you think of staffing, both for nursing homes and assisted living and home care, the other major issue is immigration. I cannot have a conversation with an operator of a nursing home or an assisted living facility or a home care agency. Whatever I call to talk to them about, they want to talk to me about one thing, and that's staffing. The Trump immigration rules are going to make what is already a serious shortage in staff even more severe. The administration has gotten off to kind of a slow start in Trump's promise to have mass deportations, but you can see the train is gaining speed. And he's not kidding when he talks about mass deportations. They've already announced that they're going to repeal a program called temporary protective status, which affects immigrants from places like Haiti and Venezuela. That program is going to be gone over the next few months. Those people who are living here under that special program are going to get kicked out. They're all going to be deported. Um, People who are here on green cards, even if they're here and they're legal and they have a green card, there's nothing to say that the Trump administration isn't going to change the green card rules. It's already begun to change the way it's enforcing the rules. So I think we can expect to see the labor shortages that already are plaguing the long-term care industry get much, much worse. We'll see where that goes. Um, I was at a conference a week or so ago talking to senior living operators, and it was really interesting. We started talking a lot about tariffs. Well, you might say, what do tariffs have to do with senior living? Well, if you want to build a facility, if you want to expand an existing facility, you need steel, you need lumber, all of that, much of that is imported. The tariffs are going to significantly increase the costs for operators of senior living and senior housing. Uh, and again, immigration changes are also going to significantly increase their costs because so much construction labor are immigrants. So I think it's going to be a very challenging time for people who are looking to build more senior living, and Lord knows we need it. Um, and it's also going to make it more expensive. It's already too expensive for most people. This is just going to make it even more expensive. I'll switch gears one more time and talk about something else I want to talk about with senior living. Uh, when you think about low income, senior living operators are heavily reliant on a program called Section 202, which are housing subsidies that make low income senior living, subsidized senior living work. Those 202 subsidies are going to be cut significantly. Um, and the staff at HUD that runs those programs is also going to be cut significantly. So I think it's going to be a very difficult time for affordable housing. Similarly, low-income housing tax credit, which is also very important, is also going to be cut. And I think it's going to be interesting to see what happens there. And finally, Fannie Mae and Freddie Mac, um, which do a lot of funding for multifamily housing, they're going to be privatized, very likely, and that's going to change the financing. So a lot going on there for senior living. Be a very challenging time for them. Let's switch gears again and talk about taxes. So here there's again kind of a mixed message. During the campaign, President Trump mentioned briefly the idea of a caregiver tax credit. Um, he never said how big it would be. He never said who would get it or when they would get it, but he did say he supported the idea of a caregiver tax credit. Since he's been president, as far as I can tell, he's never mentioned it again. He talks about tax credits for or tax-free tips and tax-free Social Security benefits and tax-free overtime. He talks about those tax breaks all the time. I don't hear him say anything about the caregiver tax credit. But there are bills in Congress, bipartisan bills in Congress, that would create such a credit. It's possible that it will show up. There are some other tax breaks that also may appear that might benefit older adults, at least some of them. One of them is the increased deductibility for long-term care insurance premiums. Currently, they're deductible, but only in a very limited way. This would make them the tax deduction much more generous. And then Republicans have always favored health savings accounts. You might see them expanded, including for long-term care. So that might be something that might also be a benefit. One thing to watch out for, is people can take the medical expense deduction for continuing care retirement communities. That may be under some pressure as Congress looks for ways to help pay for at least some of the tax cuts that are on the table. The last thing I want to talk about briefly is public long-term care insurance, which is a topic of great interest to me. I've been working on it for many, many years. Uh, some states have already begun thinking about it. Washington State has actually done it. It's created a public long-term care insurance program that provides a benefit of up to about $36,500 for people who require long-term care. It is funded with a payroll tax, a supplement of 0.6%. Washington State started collecting the tax last year. Will start paying the benefits next year. There are a number of other states that are thinking about doing this. California, Minnesota, Massachusetts, New York, Illinois, all have studies going on one way or another to look at ways to create some sort of a public long-term care insurance program. On the federal level, Congressman from New York named Tom Suozzi has introduced a bill called the WISH Act, which is also a public long-term care insurance program, but it's different from the state programs. The state programs are what they call a front-end benefit. They'll pay for your first $36,500, then you're on your own. What Swazi's proposed is what's known as a catastrophic benefit. The idea there is you would be responsible for covering the first period of time where you need long-term care. And then if you need it for a very long period of time, and the period of time will vary depending on your income, uh, then the federal government will step in and will pay for maybe $100 a day for the rest of your life. He recently got a Republican co-sponsor, Congressman Molinar from Michigan, which is very unusual these days to get a bipartisan bill, but he got one. The long-term care insurance industry is very interested in this. So the bill called the WISH Act is getting a little bit of traction in Congress. Now it's not going to happen in the current political environment, but it is something to watch, and it may get more interest as time goes on, and as of course older adults, more and more older adults need this support. Let me just conclude by saying that um, I can't really predict what's going to happen in the Trump administration. His management style is too impulsive. It's too chaotic. There are deep divisions among congressional Republicans over some of what the president wants to do. They're not talking about it publicly, but privately, I'm beginning to hear about concerns about some of his proposals. The tariffs, even more public, of course. There are disagreements among his top advisors among a number of these proposals. I mentioned the disagreements among his advisors on Medicare. It's beginning to show up in some other areas as well. And then Trump's declining popularity might affect his ability to get some of this done as well. So a lot to think about. I'm happy now to stop talking and to take some questions. So thank you all for listening.
Wow, that was very thorough, Howard, and I really appreciate your preparation. That you covered a lot in a very short period of time. Okay, so let's dive into some of these questions and additional discussion. Medicare Advantage seems to be the theme of a lot of questions, and I'm sort of looking at several right now, folks. So if I'm not calling you out by name, that's why. But you know, the I think some folks cited that Medicaid Advantage programs, there's limited choice, there's some network instability in rural areas. We've got somebody in Western Massachusetts that is having challenges there. Any thoughts or insights on that, Howard?
So I am strongly of mixed mind about Medicare Advantage. Medicare Advantage, in theory, has an enormous benefit over fee-for-service traditional Medicare. And that is that it holds the promise of being able to coordinate care, organize your care so you don't have this fragmented mess that you have in the rest of the medical system. The idea that you could actually go to a primary care doctor who would help you get to a specialist, who would help you provide the social supports and services you need, who would make sure that you weren't getting multiple prescriptions for the same drugs because you were seeing different doctors who didn't talk to each other. It's a tremendous opportunity. And it has, at least in theory, the potential to keep people out of the hospital, save the system money, and keep people healthier. The problem is that it isn't really meeting its goals. Um, it's less fragmented, but the price of less fragmentation is the networks and the complexity and the prior authorizations and all the rest. So the hope is that we could figure out some way to make Medicare Advantage really work, and make managed care in the positive sense really achieve what it wants. The problem is we're not getting there. And the plans are getting lots of money, and not providing the services. The other thing to say about it is, um, it's not just healthcare. It's also long-term care. It's post-acute care. And if you're a nursing home operator, you're getting paid significantly less by Medicare Advantage than you're being paid by traditional Medicare. And that means you've got less resources to provide the care that your residents and your patients need. So it gets complicated.
Um, Thank you. And lots of questions and people that are impacted by Medicare Advantage, but what have you. Now, I've noticed in the comments and Susan's question here, the amount of taxes we pay locally and federally stays the same while they're cutting everything and reducing services. What can we do? And I noticed, Susan's asking this question. Several people are like, we need to get out there and march and rally. Howard, from your perspective, like, what are some things that we can do as individuals or as a community? The positive aging community, what can we do to impact change?
So, I'm old enough to have grown up in the anti-war movement and gone on my own marches and my own demonstrations and all of that. Um, in this environment, I think marching is probably not the most effective way to get your message across. Remember that, at least on the federal level, Republicans are in charge, and yelling at them and waving signs at them is really not going to do it. What you need to do is convince Republicans in Congress that some of what I was talking about, that the Trump administration wants to do, is not very beneficial to older adults and their families. And the way you do that, to my mind, is you sit down with members of Congress or with state legislators or governors or whoever it is, and just help them understand, if you're a family caregiver, what your life is like, what a day is like to be a family caregiver, how hard it is, how difficult it is to try to keep down a job and take care of the kids and take care of mom. And every time the phone rings, you jump out of your skin because you're afraid it's another crisis. Just helping them understand what that's like, uh, I think is a very important message to send. And a lot of members of Congress don't know it. Those who have been family caregivers, they get it, but otherwise they don't. And the staffs, they're 25-year-old kids, they're 30-year-old kids. They've got no experience in this. But helping them understand what's going on, I think, is a really important message. If you're a provider, I think it's the same thing. I mean, you can tell your story and you're an employer in the community and people care about you and they know you. But it's also really important for the families of your residents, or if you're a home care agency, family of your clients, to tell their story. And again, to help politicians understand how important your services are, and how, I was going to say difficult, it's more than difficult, it's impossible your clients and your residents' lives would be like if they didn't have the services that you're providing. So I think it's a matter of telling a story. And that's probably the best way to do it right now.
Yeah, no, I agree. The storytelling is key. So folks, if there's anything, if you've got a story to tell, or if you've got something, feel free to reach out to me. Maybe there's a creative way that we can package the story and then push it to the lawmakers. I will say, one of the benefits of, I know several people are talking about showing up for the marches and things like that. I I think less effective in impacting change, but being part of a community, it's a community building thing, and there can be value in that for
Yeah.
sure.
Yeah. And I saw somebody in the chat said that they send letters. They frequently send letters. Years and years ago, I worked in Congress. Members of Congress do read letters. They don't read, mass letters. They throw those out. But if individual letters from individual people, they do read. But it's not as effective as sitting down with them. And you hear stories about some members of Congress now won't hold town meetings because they get yelled at. But a lot of them still do. And showing up at town meeting again and just telling your story is really, really powerful.
Yeah, and that's going to be recorded. There's at any town meeting,
Yep.
there's a record there. There'll be reporters there as well. Um, let's see. Barbara says, did I read this correctly? The SHIP program nationwide had been eliminated, and the SHIP is the Senior Health Insurance Counseling Program, I believe.
Right. So the SHIP program, it's a stupid name. It's a state health insurance program. It has nothing to do with state health insurance. It's about Medicare. It's the program that provides advice to consumers about how to apply for Medicare. As far as I know, it's still there. I don't think it's been eliminated.
Okay. All
Um,
right.
uh, but again, it's one of these things that is in some jeopardy. I think it's going to be a challenge, but it's a very important program. I was the board chair of the Jewish Council for the Aging in suburban DC, and we run the SHIP program from Montgomery County and get a lot of calls. It's very, very important, and I hate to see a program like that go. But as far as I know, it's still running.
Okay. Jose is asking about the future of the PACE program, which is a wonderful program. Any insights on that?
So PACE, for people who are not familiar with it, is a very interesting program. It's a combination of Medicare and Medicaid for people they call it dual eligibles. People are eligible for both programs. It's run by the states. Mostly, not all the time, but mostly it's run around an adult day program. So you go to adult day, there are actually medical services provided along with the adult day programs. There are home care services that are provided, a whole range of home care services. It's a terrific program. It's been around for decades. There are not a lot of them. In Maryland, for years and years and years, there was only one in the entire state in Baltimore. Just recently, there's a second one that just opened. But DC, does DC have a PACE program? I think it may have one.
No, but Northern Virginia has the Cherry Blossom PACE, and I just put the link to the nationwide a link on the nationwide PACE programs.
It's a great program. The trouble with it is, again, is going to be if Medicare and Medicaid are cut, that's going to significantly limit the resources to be available for PACE. So we'll see what happens. It really is a terrific program. I've done site visits at a number of them around the country, and they're really very, very good.
Okay, and then we were talking about this earlier, but the Medicare Guide program, any thoughts on what could happen to that?
So Guide is a wonderful brand new program, started in the Biden administration. And the idea is that if you get a diagnosis of dementia, um, a Medicare provider, who could be a home care agency, could be a nursing home. Well, actually, it couldn't be a nursing home because it's nursing homes are exempted. The only people living at home, but could be a home care agency. It could be a physician. It could be a health system. Um, all of them could follow up that diagnosis of dementia with care navigation services, with the assistance that people need in getting the social supports that they require once they've gotten a diagnosis. It also provides a certain amount of support for family caregivers. It's an experimental program. It's got an 8-year runway, which is a long time for one of these experimental programs. Um, and the way it works is Medicare pays providers who offer this service an additional amount of money per month for every patient who gets this additional service. It's a couple $100s a month. It's a great idea. I wish it wasn't just limited to dementia, but so you got to start somewhere. I don't know if the Trump administration is going to continue it or not. What I'm hearing is that it probably will, but it may try to make some significant changes in the program. One change that they're talking about, for example, is right now the providers are paid for, say, a medical practice is paid a couple of $100s a month for doing this, but there's no risk involved. Um, the Trump administration loves the idea of risk. They want providers to get a benefit, but also get penalized if they don't provide a certain amount of service. So they may try to turn it into a risk-based program. Again, we'll see. But it's a great experiment. It's a great idea, Steve. I know you're going to have a program on Guide, and I think it's going to be worth everybody watching because it's a terrific idea.
Yeah, and but I tell you, like based on the cuts to the probationary government employees, whenever I hear something you when you said it's an experimental program, you just with the questionable, like you said, it's you can't predict what may happen with these changes, and
And the other thing that's really sad is the Trump administration has been sort of methodically getting rid of data collection and data analysis all through the government for all sorts of agencies. Um, and my fear is they're going to do something like the guide program and not collect the data and not analyze the data. So we're never going to know whether it worked or not, which would be a terrible waste, a terrible loss of a great idea.
Yeah, okay. Barbara has a question. What risks do you think continuing care retirement communities might face, both from the organization and the residents? Are they less risky because this is uh, a private operation?
So full disclosure, I'm on the board of Ingleside, which is a local continuing care community in the DC area. Um, I think CCRCs have a number of risks. One of them is, of course, if your CCRC includes a nursing home, you have skilled nursing, Medicare payments, are going to be at risk. Um, if you have Medicaid, um, most don't, but some will. Again, the Medicaid cuts could be a real risk. As I said before, if you're thinking about doing any kind of construction, any expansion on your current site or any new building anywhere else, the tariffs, the immigration restrictions are going to raise your costs substantially. So I think you're going to need to watch out for that. Um, and then the other thing that I mentioned before, which I think is a sleeper issue, but keep an eye out on it, is what is going to happen to the medical expense deduction for CCRCs. And that's something that could be in a little bit of jeopardy.
Hmm.
So I think there are a number of risks, even in a largely private pay environment.
Burke has a question. When you say Social Security goes bankrupt down the road, do you mean outlays exceed contributions? And maybe elaborate a little bit on Social Security insolvency and what you feel is the most appropriate solution to minimize the impact of that.
Sure. So it would probably take another hour for me to
No,
talk
I
about
know, I
Social
know.
Security, but let me give you the very short version. So the way Social Security basically works now is current workers pay into the system, and what they pay into the system is the money that's used for retirees. The whole story about you're paying into the system and you've got this money stashed away in your account, it isn't true. So essentially, it's a pay-as-you-go system now, has been for some years. Uh, the problem will be, as you said, that what's going to happen in a few years is there will not be enough money paid in by working people to pay the benefits for retirees. Um, when that happens, um, Congress is either going to have to change the law or there'll be this across the board cut in benefits for everybody. How do you fix it? You know, it's really interesting when you think about how you're fixing a program like Medicare, it's really hard. It's really, really complicated because delivering healthcare is really complicated. It's not hard to understand how you fix Social Security. People have had, for decades, they've had this menu. And on one side, you have how to reduce benefits or reduce promised benefits. And on the other side, you have how to raise taxes. Everybody understands that if you did a little bit of both, you can make the program solvent for the next 75 years. The trouble is there are no politicians who want to do a little bit of both. You have you have Republicans who all they want to do is they want to cut benefits, and you have Democrats all they want to do is they want to raise taxes, and nobody wants to get together and come up with the obvious solutions. It's a tragedy. And Congress being Congress, I said before it's going to be, 8 or 9 years. They're going to say we're going to wait till it's 7 or 8 years and let somebody else worry about it. I'm not going to do it now.
Okay, let's see. Herbert says if Medicaid begins to be funded through block grants, is there anything that the individual states can do to fill in those gaps?
Well, sure, they can raise their own taxes and they can fill in the gaps, but they're not likely to do that. It's so much money. You mentioned before, the feds already now pay 70% of the cost of Medicaid. States
Hmm.
only pay about 30%, and some states pay less than that. It's a lot of money. It's an enormous program. In many states, it is the biggest or second biggest program that the state runs. Um, so yes, the states in theory could make up the difference if the feds cut, but in practice, there are no states that can afford to pick it all up. So it's going to mean there'll be cuts in Medicaid programs.
All right. And I'm looking at the clock. We got about 5 more minutes with Howard. And let's see. Elizabeth asks, and this is in reflection of Social Security, would it be fair to increase the retirement age to reflect the increase in lifespan? Um, I know that's always something that's thrown out there as a solution.
Yeah, I mean, I think absolutely. I mean, a lot of people have analyzed it, say you don't count from age 62 forward, you count from the number of years that you're likely to live longer. And life expectancy for people over age 65 has increased dramatically since Social Security was created, even increased significantly since the last time we tried to fix Social Security 30 years ago. So yeah, I think there's nothing wrong with I with raising the retirement age, not the initial retirement age, but the age of full benefits beyond age 70. Um, but the other thing I would do at the same time, this is not just a story about cutting benefits. The other thing I would do is there are those people who are lifetime low income workers who are not getting sufficient Medicare, Social Security benefits. And I would raise the benefits that they get. I would raise the benefits that widows get, surviving spouses get. And I would lower a little bit the benefits that very high income people get. I'm getting a very generous Social Security. I don't need it all. I'd be perfectly willing to take a little bit less if somebody else could get a little bit more and the program could stay solid. So sure.
Yeah, I agree. I think those are great solutions. Barbara asks, how will the area agencies on aging be affected? Have any of the changes that have currently been made impacted the area agencies on aging?
So the AAAs are funded. They're another program funded by the Older Americans Act. Um, so they will be caught up in any across the board cuts in domestic spending that affect the Older Americans Act. They also will be caught up in these cuts to the Administration for Community Living. Same story. If you are AAA and if you need to get your grant renewed, there's nobody at the other end of the phone to answer the grant. In fact, right now, the staff at the Administration for Community Living is prohibited from answering calls from grantees, except under very limited circumstances.
Wow,
It's crazy, but that's kind of how it goes. So yes, the AAAs could significantly be impacted.
man. Well, Howard, you're getting tons of kudos on your presentation, and I totally agree. And I can't believe that we've got through most of the questions, folks. I paraphrased a lot of them, but I think that's just a testament to how clear and succinct you were in your presentation. I am really impressed at your breadth and your and many people your objectivity here. Like this was not you spoke very clearly from a nonpartisan viewpoint.
Thanks. And let me just say one last thing before we all go. I think that just complaining about it and worrying about it isn't going to be enough. I think it's very important for communities, faith communities, senior villages, other kinds of communities to get together and say this is a time more than ever that we need to work together cooperatively to help older adults and their family caregivers who are going to be struggling over the next several years. So, let's find ways to work together and make this and do what we can on a community level.
Yeah, and as you were talking, I mean, and seeing all the passionate comments that were coming in, I think folks, let's all brainstorm together as a group listening to Howard today, because I think if we point our ship in one direction, our community here, just those listening to this webinar today, we could make an impact. And so feel free to reach out to me if you've got ideas or if you want to sort of take a role in pointing our little community here together. I think this could be a very positive initiative. And again, it's one of these things we can't rely, even if things were going perfect in the world, we can't rely on 100% on the government. We need to act as a community and take care of each other as well. So I love the direction of this, Howard. You've really given me personally a lot of things to think about, and I can tell our audience as well.
Thank you. It's a pleasure to be with you always, Steve. Good
Yeah.
to talk to you.
And so folks, just so you know, all this is recorded. I'll get it up as quickly as I can and get it at proaging.com, and you can share it with folks. Howard, again, thanks so much for your time today. And I look forward to our next conversation, and hopefully things we begin to see some more positive changes.
I hope so, and looking forward to doing it again sometime soon. Take